Now we'll be covering Chapter 29, Clinical Virology, Part 2. This section of Chapter 29 covers single-stranded RNA, viruses, hepatitis viruses, prions, and then a section on antiviral therapy. The next set of slides will discuss single-stranded RNA viruses. There are several family of single-stranded RNA viruses, and among those family exist various members and genre. The group members presented here include Arenoviridae, Bunявiridae, Calciviridae, which includes norovirus and sapovirus, Coronaviridae, which includes coronaviruses such as SARS, Filoviridae, that includes Lake Victoria Marburg virus and Ebola virus, and Flaviviridae, that includes viruses such as Japanese encephalitis virus, dengue virus, and yellow fever. In addition, Flaviviridae includes St. Louis encephalitis virus, West Nile virus, and Zika virus. The family Orthomyxoviridae includes the influenza viruses A, B, and C. Paramyxoviridae includes parainfluenza viruses, the mumps virus, measles virus, and RSV. Picornaviridae includes enteroviruses. Retroviridae includes viruses such as human immunodeficiency virus. Rhabdoviridae includes Lyssa viruses. Togaviridae includes Eastern equine encephalitis virus, Western equine encephalitis virus, Venezuelan equine encephalitis virus, and rubella virus. And finally, hepatitis viruses, Hep A, B, C, D, and E. So all these group members mentioned here will be discussed in more detail, along with others that are clinically significant in each family. The arenaviruses get their name from the Latin word arena, meaning sand, because under an electron microscope, arenaviruses appear sandy and granular. There are 43 named arenaviruses, and the family includes many species that cause hemorrhagic fever. Arenaviruses are commonly divided into two groups, Old World and New World viruses. Arenaviruses can be transmitted via contact with aerosolized virus or contact with fomites with infected rodents. The most well-known member of arenaviruses is the Lassa virus. Symptoms of Lassa virus include fever, headache, pharyngitis, myalgia, diarrhea, and vomiting, although most exposed individuals develop asymptomatic infection. Severe symptoms may occur and include pleural effusions, hypotension, and hemorrhaging, and the virus can also cause meningitis. As mentioned before, transmission is by inhalation of aerosolized virus. It can also be contracted from breaks in the skin. It can be community acquired by contact with excretions of rodents. West African nations are those that are most affected by outbreaks of this disease. ELISA testing has been used to detect Lassa virus by detection of IgM and IgG antibodies. Treatment of infection is started within 6 days of exposure and treated with ribavirin. The family Bunявiridae includes the genre Orthobunyavirus, Flebovirus, and Norovirus, which are all classified as arboviruses. These viruses replicate initially in the gut of the arthropod vector and eventually appear in its saliva. The arthropod then transmits the virus when feeding on the blood of vertebrate hosts, including humans. After a few days, the infected host usually develops an asymptomatic viremia. However, some hosts become febrile, which is less common. Most members of the family Bunявiridae cause a febrile illness. hemorrhagic fever, or encephalitis. Rift Valley fever virus, a phlebivirus, causes encephalitis and hepatitis, and the virus specifically targets the brain and liver. La Crosse encephalitis virus and California encephalitis virus, members of the Bunya viruses, can cause aseptic encephalitis and aseptic meningitis, respectively. Both of these viruses target the brain. Congo-Crimean hemorrhagic fever virus is a member of norovirus, and this causes hemorrhagic fever. It targets vascular endothelium and liver and is associated with a high mortality rate. Hantine, Sol, Pumala, and Dobra viruses, members of hantavirus, cause hemorrhagic fever with renal syndrome. These infections are mostly seen in Europe and Asia, with the exception of the Sol virus, which is seen worldwide. The last member of Bunya viridae to discuss is the SNV virus, also known as sin nombre virus or no-name virus. This is known as a New World hantavirus, and it's the causative agent of hantavirus pulmonary syndrome. This was originally found in New Mexico in 1993, where 2 adults from the same household died of an unusual respiratory illness. The virus is transmitted via inhalation of contaminated, aerosolized infected rodent urine, saliva, and droppings. Clinical manifestations occur 3 to 5 days with prodrome of fever, chills, and myalgia. Several hantaviruses cause pulmonary syndrome. Sin nombre, Black Creek, Canal, Bayou, Monongahela, and New York have been found to cause illness in the U.S., while the others have been identified in various countries, including Canada and South America. Various rodents are the host of these viruses, such as the deer mouse and several species of rat. As mentioned before, SNV manifests 3 to 5 days with febrile illness. Then patients enter a phase of hypertensive shock and pulmonary edema. The patients develop tachycardia, hypoxia, and hypotensions, and some patients will develop disseminated intravascular coagulation. The mortality rate for those infected with sin nombre virus is about 50%. Enzyme immunoassays have been used to detect anti-SNV, IgM, and IgG antibodies, along with immunohistochemistry testing. Treatment of this infection is supportive, so there is no antiviral therapy indicated. The family Calciviridae contains 5 genera: norovirus, sapovirus, nebovirus, lagovirus, and vicivirus. Noroviruses are the most common cause of infectious gastroenteritis in the U.S. The populations at risk include individuals in schools, colleges, nursing homes, and families on cruise ships and in resort areas. Viruses can also be found in drinking water, swimming areas, and contaminated food. Transmission is most commonly foodborne, but can also occur waterborne and person-to-person contact, and this can be significant. This is a micrograph of norovirus virions. So remember, norovirus is a non-enveloped virus having the shape of an icosahedral capsid, so it observes a more spherical shape. The incubation period for noroviruses is 24 to 48 hours. The onset of symptoms include severe nausea, vomiting, diarrhea, and low-grade fever, and the onset is abrupt. The infection rate can be as high as 50%, and the illness usually subsides within 72 hours. Immunity may be short-lived, leading to the potential for multiple infections throughout life. The viruses cannot be grown in culture, so diagnosis relies on electron microscopy immune electron microscopy, and real-time PCR. A newer assay using real-time reverse transcriptase PCR is now the most commonly used diagnostic assay for detecting noroviruses. Sapoviruses are another genre that belongs to the family Calliciviridae. These viruses cause diarrhea and vomiting in infants, young children, and older patients. Detection methods for this virus include electron microscopy, molecular methods, and immunologic methods. Coronaviridae is the next family we'll discuss. This is also known as coronaviruses. These viruses were so named due to the distinctive club-shaped projections on their surface. Coronaviruses cause 15% of cold-like infections in adults. Higher seroconversion rates have been seen in children. Aside from the cold-like infections, coronaviruses can also cause some cases of pediatric diarrhea, and it's been seen that the virus targets the GI tract in children. Transmission of coronaviruses is via person-to-person by direct contact, droplet, or airborne routes. Also, the virus can be found in urine and feces. This electron micrograph of coronavirus shows the distinct club-shaped projections, of which the name was derived from the appearance of the halo or corona surrounding the virion. Today, the most common diagnostic approach for identification of coronaviruses is amplification and detection of virus-specific RNA. Assays using a 1- or 2-step real-time PCR procedure for the amplification stage are the most popular. Other nucleic acid-based tests include isothermal amplification methods and loop-mediated amplification. These are typically used in research or larger reference laboratory settings. A novel coronavirus was the causative agent of a pandemic respiratory disease that emerged from Hong Kong in late 2002. The virus infected at least 8,000 people and resulted in a mortality rate of approximately 10%. The disease was characterized by high-grade fever, pneumonia, and in some patients, acute respiratory distress syndrome. This is how the disease was named. It was ultimately termed severe acute respiratory syndrome, also known as SARS, and the causative agent was designated as the SARS-associated coronavirus. This infection required a hospitalization and intensive care, and it could rapidly spread with close patient contact. The next family we'll discuss is Filoviridae. So this family includes two genres, the Marburg virus, now known as Lake Victoria Marburg virus, and Ebola virus. The Ebola virus includes several strains, including the Ebola Sudan, Ebola Zaire, Ebola Reston, and Ebola virus typharis strain, formerly known as the Ivory Coast strain. First, we'll discuss Lake Victoria Marburg virus. So this was named after the location of the first outbreak in Marburg, Germany. Symptoms of Lake Victoria Marburg virus hemorrhagic fever include a high fever for 12 to 22 days, a maculopapular rash on the trunk and extremities, worsening nausea, vomiting, and diarrhea, and patients begin bleeding from the nose, gums, and gastrointestinal tract. Diffuse hemorrhaging, shock, multiple organ system involvement leads to a high mortality rate of this infection. Lake Victoria Marburg virus is transmitted via contact with either infected monkeys or infected patients. The infection can be diagnosed using PCR, immunohistochemistry, or IgM capture ELISA testing. Treatment of Lake Victoria Marburg virus infection includes supportive care and replacement of blood and clotting factors. Ebola virus is the other significant group member of the family Filoviridae. Symptoms of Ebola virus hemorrhagic fever include fever, chills, myalgia, and anorexia 4 to 16 days after infection. Sore throat, abdominal pain, diarrhea, vomiting, and bleeding from injection sites and the GI tract can also appear. Hemorrhaging in the skin and internal organs can occur as well. Laboratory testing includes PCR, immunofluorescence, or viral culture methods. Electron microscopy can also be used and will yield the characteristic virions. This electron micrograph of the Ebola virus shows the characteristics of filoviruses. They appear thread-like in structure and helical with non-segmented, single-stranded RNA. They may also appear polymorphic and vary in length. Ebola virions specifically appear tubular, and they vary in shape and can appear as U-shapes. The next family, Flaviviridae, includes a number of important human pathogens, many of which are zoonotic arboviruses. Japanese encephalitis virus ranges from influenza-like illness to encephalitis. This virus is an emerging pathogen. Dengue fever virus causes two distinct diseases transmitted through bite of a mosquito. The first disease is a milder disease, classic dengue fever. Symptoms include fever, headache, myalgia, bone pain, and sometimes a rash. Classic dengue fever is a self-limiting infection and is non-fatal. The second distinct disease, dengue hemorrhagic fever, is more severe. The symptoms include those associated with classic dengue fever, along with thrombocytopenia, hemorrhage, and shock, and sometimes can result in death. Yellow fever caused by yellow fever virus is also considered an emerging infection. Patients bitten by mosquitoes carrying yellow fever virus can develop an asymptomatic or acute infection involving fever, myalgia, back pain, headache, anorexia, nausea, and vomiting. Most patients experiencing acute disease recover after about 4 days. However, about 15% of the cases enter a systemic toxic phase in which fever reappears. The patients develop jaundice and bleeding from the mouth, eyes, nose, stomach, or other areas. The kidneys may fail, and about 50% of the patients in the toxic phase die. There is a vaccine available, and although it is safe and has been available for decades, there's been large numbers of cases of yellow fever that result in deaths, and these are reported annually worldwide. The natural host of yellow fever virus is monkeys, and it's transmitted through the bite of mosquitoes. Yellow fever is still epidemic in parts of Africa and South America, where about 80% of the population needs to be vaccinated to reduce the impact of the disease. There are 3 different transmission cycles for yellow fever virus. They are sylvatic, urban, and intermediate cycles. In the sylvatic cycle, yellow fever virus is maintained in monkey populations and transmitted by mosquitoes. Monkeys become viremic to pass the virus to mosquitoes as they feed on the monkeys, thus keeping the transmission cycle active. Humans are not the usual hosts when they occur in the jungle areas in which the sylvatic cycle exists. The urban cycle occurs in larger towns and cities when infected mosquitoes transmit the infection to humans. Because infected humans can continue transmission when bitten by uninfected mosquitoes, large outbreaks can occur from a single case of yellow fever. Finally, the intermediate transmission cycle of yellow fever occurs in smaller villages. In this cycle, humans and monkeys are reservoirs, and mosquitoes are the reservoirs and vectors in the high morbidity, low mortality outbreaks. In the intermediate cycle, mosquitoes can transmit yellow fever virus from monkeys to humans and vice versa. If the patient who develops yellow fever from the intermediate cycle travels to a larger city and is bitten by mosquitoes, they can trigger an outbreak of urban yellow fever. The most common flavivirus infection is St. Louis encephalitis. Patients with the virus are most likely to be asymptomatic, but symptomatic patients may develop a fever only, whereas some patients go on to develop meningoencephalitis. The mortality rate of symptomatic patients is 3 to 20%. Unlike many of the arbovirus infections, St. Louis encephalitis is milder in children than adults, and older patients have the greatest risk of serious illness and death. St. Louis encephalitis is transmitted to humans by the mosquitoes culex that bite birds. Most infections occur in the summer months. The West Nile virus is a single-stranded RNA virus and a member of the Japanese encephalitis antigenic complex, similar to St. Louis encephalitis. The virus is transmitted by a mosquito vector between birds and humans. The virus replicates actively inside the avian host, but it does not replicate well in humans, making humans the dead-end host of infection. Patients may be asymptomatic, but if they are symptomatic, West Nile fever occurs, in which symptoms include headache, fatigue, occasional skin rash, swollen lymph glands, eye pain, and of course fever. Some patients develop meningitis or encephalitis, usually occurring in adults over 50 years old. Laboratory tests approved for detection of West Nile virus include IgG and IgM ELISA, including a rapid West Nile virus ELISA assay and an indirect immunofluorescence assay to screen for antibodies. West Nile virus ELISA assays can cross-react with other flaviviruses and should be confirmed by antibody neutralization. A number of real-time PCR, TACMAN, and nucleic acid sequence-based amplification assays have been used for successful confirmation of West Nile virus. There is no specific treatment for the infection, but in severe cases that require hospitalization, supportive care, and IV fluids, along with respiratory support, may be warranted. Zika virus is a member of the family Flaviviridae that has been in the news more recently in the past couple of years. Zika virus is a mosquito-transmitted disease that can also be transmitted via infected blood or sexual contact. Although the textbook mentions that there was no transfer of the virus to the fetus, now it's been shown that Zika virus can have effects on the fetus and newborn if a pregnant mother is infected. The virus is endemic in areas of Africa and Asia, and a significant number of cases have been reported across South, Central, and North Americas. Symptoms of Zika virus infection include fever, headache, fatigue, and microcephaly in newborns. The FDA has looked to rapidly approve PCR-based assays to allow for rapid testing for pregnant women, which can be coupled with serology testing for both IgG and IgM antibodies. This helps in diagnosing potential Zika virus exposure or infection. Of note, currently, molecular RNA testing and IgM ELISA testing is available for detection of Zika virus. The CDC has issued assessment algorithms used to determine if the laboratory testing is warranted. The next family of viruses, Orthomyxoviridae, is one that you are all familiar with. The members include influenza viruses. So influenza viruses are enveloped members that can be distinguished using two major structural proteins: matrix proteins, also known as M proteins, and nucleoprotein, known as NP. Influenza is distributed worldwide, and it can originate as a zoonotic infection, so it can be carried by different species of birds and mammals. Influenza season varies depending on location. In the southern hemisphere, the season ranges from May to October, and in the northern hemisphere, it ranges from November to April. The key to the persistence of influenza virus is its antigenic variation. Each year, antigenic drifts are caused by RNA replication errors of the virus. Remember, we discussed antigenic drift in immunology, so that's the minor change in antigenic structure as mutations accumulate in the virus. Antigenic drift occurs with all three influenza viruses, A, B, and C. When the surface antigens change drastically, an antigenic shift occurs that results in a new antigen, known as H or N. Of note, antigenic shift is only associated with influenza A virus. Three major antigenic shifts occurred during the 20th century. Infection with influenza A virus, H1N1, the Spanish flu, appeared in 1918 to 1919. H1N1 was the predominant strain until a shift to influenza A virus H2N2 occurred in 1957. That shift resulted in the pandemic Asian flu. Then, in 1968, another shift occurred, and a pandemic strain of influenza A virus H3N2 resulted in the Hong Kong flu. The dominant strains of influenza A virus since 1977 have been influenza A viruses H1N1 and H3N2. In 1998, an outbreak of infection with influenza A virus H5N1, the avian flu, appeared in poultry in Hong Kong. The H5N1 strain is a highly pathogenic avian influenza virus. Historically, most human infections are acquired after direct or close contact with infected birds. The H5N1 virus had appeared in flocks of birds in parts of Asia in 2004 and then again in 2005, resulting in large losses of poultry in Japan, Cambodia, China, Vietnam, and nearby countries. In the spring of 2009, a highly infectious novel form of influenza swine flu caused by influenza A H1N1 emerged. It was first reported throughout Mexico. From April 2009 to July of 2009, the CDC reported over 43,000 cases of this H1N1 infection. The World Health Organization defined this as a pandemic. By April of 2010, the World Health Organization announced that the H1N1 influenza virus had moved into the post-pandemic period. And finally, more recently, there has been an increase in infections by the influenza variant H3N2V. This is a non-human influenza virus normally found in swine. When viruses that normally circulate in animals infect humans, they are termed variant viruses. So H3N2V virus was detected in humans first in January of 2011, and it had genes from avian, porcine, and human viruses. Most of the cases in the United States occurred in Indiana and Ohio and were linked to farm activities, livestock shows, or county fairs. Influenza viruses are spread through aerosol inhalation. The viruses attack the ciliated epithelial cells lining the respiratory tract, causing necrosis and sloughing of the cells. The incubation period is 1 to 4 days. Although asymptomatic infections can occur, infections are usually characterized by rapid onset of malaise, fever, myalgia, and often a non-productive cough. Temperatures can be as high as 41 degrees Celsius, and infected patients are ill for as long as 7 days. Influenza can also be fatal and cause viral pneumonia. Complications include secondary bacterial pneumonia. Of the three influenza viruses, influenza A and B infect mammals and avian species. Influenza C causes mild upper respiratory illness in humans. The appropriate specimens for laboratory testing include nasopharyngeal swabs, nasopharyngeal washes or aspirates that are collected early on in infection. Flocked swabs are better at collecting epithelial cells, so are the preferred type of collection device. Specimens for influenza testing should not be frozen. Various rapid kits are commercially available for diagnosis of influenza. Some of these kits are low complexity and have CLIA waivers, so they can be performed in doctors' offices and clinics. Influenza virus can be identified in respiratory secretions by using DFA, EIA, and optical immunoassays. Influenza viruses can also grow in the amniotic cavity of embryonated chicken eggs and various mammalian cell culture lines. Nucleic acid-based assays are also used for detection of influenza virus, with the most common method being real-time PCR. Molecular testing is sometimes used in conjunction with rapid antigen kits. The antiviral drugs amantadine and rimantadine can prevent infection or reduce the severity of symptoms if administered within 48 hours of onset of infection. These antiviral drugs are effective only against influenza A virus. A newer class of antivirals known as neuraminidase inhibitors is also available. These agents, such as zanamivir, known as Relenza, and oseltamivir, generically named Tamiflu, are more expensive compared with the other antivirals, but provide coverage against infections by both influenza A and B viruses. Several genera belong to the family Paramyxoviridae. There's 4 types of parainfluenza viruses that can cause human disease, and they're known as PIV1 through PIV4. These include parainfluenza 1 and 3 and parainfluenza 2 and 4. Parainfluenza viruses are enveloped helical RNA viruses with 2 surface antigens, hemagglutinin neuraminidase antigen and fusion antigen. Hemagglutinin neuraminidase antigen is the viral adhesion molecule, whereas the fusion antigen is responsible for the fusion of the virus to the cell and of one infected cell to another infected cell. Parainfluenzas are the primary cause of respiratory disease in young children. PIV1 and 2 cause the most serious illness in children between ages 2 and 4 years. Parainfluenza virus 1 is the primary cause of croup, a disease that you may be familiar with that causes laryngotracheobronchitis in children. Parainfluenza virus 3 causes bronchiolitis and pneumonia in infants and is second in importance only to RSV. Parainfluenza virus 4 generally causes mild upper respiratory tract infections. The viruses are spread through respiratory secretions, aerosol inhalation, and direct contact. Infection of the cells in the respiratory tract leads to cell death and inflammatory reaction. This happens in the upper and lower portions of the respiratory tract and can result in symptoms of rhinitis, pharyngitis, laryngotracheitis, tracheobronchitis, bronchiolitis, and pneumonia. The best specimens for viral culture are aspirated secretions and nasopharyngeal washes. Specimens for viral isolation should be taken as early in the illness as possible, kept cold, and inoculated into the cells as soon as possible. The viruses can be identified by using hemoabsorption, immunofluorescence, or EIA techniques. Direct examination of nasopharyngeal secretions by IF can give rapid results. serologic assays are more valuable for epidemiologic studies than for diagnostic purposes. Some newer nucleic acid assay panels now include viruses parainfluenza 1 through parainfluenza virus 3, and this aids in treatment and epidemiology efforts. The mumps virus is related to parainfluenza viruses. It's an enveloped virus that also has the HN and F surface antigens that the parainfluenza viruses had. The mumps virus is transmitted via droplets of infected saliva and primarily infects children and adolescents. The MMR vaccine has greatly reduced the incidence of mumps infections, although recent outbreaks have occurred, such as the one that occurred in 2006 in the lower Midwest, and then even more recent outbreaks in 2016 to 18 in the United States, with some states reporting over 100 cases, such as New York, Pennsylvania, Virginia, Illinois, and Texas. The mumps virus is the causative agent of infectious parotitis. So symptoms of this infection include swollen parotoid glands, and it also may include swelling of testes, ovaries, and pancreas. The mumps virus can cause permanent sterility, and there have been rare cases reported of meningitis. The mumps virus can be isolated from infected saliva and swabbing of the Stenson duct from 9 days before onset of symptoms until 8 days after parotoid gland swelling appears. The virus can also be recovered from urine and CSF samples. Paired sera can be tested for mumps antibody by enzyme immunoassay, immunofluorescence, and hemagglutination inhibition tests. Paired sera taken at as small as an interval as 4 to 5 days can demonstrate a diagnostic or fourfold rise in titer. Virus isolation is the preferable method, although most physicians rarely have trouble recognizing mumps clinically. The measles virus is an enveloped virus that belongs to the genus Morbillivirus. It's also known as rubeola. The measles virus is part of the MMR vaccine. It's a highly contagious virus that's spread by aerosols. Initial viral replication takes place in the mucosal cells of the respiratory tract. Then they replicate in the local lymph nodes and spread systematically. The virus circulates in T and B cells and monocytes until eventually the lungs, gut, bile duct, bladder, skin, and lymphatic organs are all involved in infection. After an incubation period of 7 to 10 days, there is an abrupt onset with symptoms of sneezing, runny nose, cough, red eyes, and rapidly rising temperature. About 2 to 3 days later, a maculopapular rash appears on the head and trunk. Koplik spots, which are lesions on the oral mucosa consisting of irregular red spots with a bluish-white speck in the center, generally appear 2 to 3 days before the rash and are diagnostic of the measles virus. Complications such as otitis, pneumonia, and encephalitis may occur. A progressive, highly fatal form of encephalitis can also occur but is rare. In developing countries with malnutrition and poor hygiene, measles can have a high fatality rate. Infection confers lifelong immunity once an individual has resolved symptoms. Here's an example of Koplik spots, the lesions on oral mucosa consisting of irregular red spots with a bluish-white speck in the center. Again, these are diagnostic of measles virus infection. Measles is easily diagnosed clinically, so there are few requests for laboratory identification. The virus is fragile and needs to be handled carefully. If laboratory testing is warranted, specimens of choice are from the nasopharynx and urine, but the virus can be recovered from these sources only in the early stages of infection. Virus isolates can be identified by using serum neutralization, EIA, or IF tests. Serologic diagnosis of measles is accomplished by demonstrating measles-specific IgM in the specimens collected during the acute phase of the disease. Nucleic acid should be considered for diagnostic use if IgM testing is compromised by the recent use of measles virus-containing vaccine as part of a routine vaccination or in response to a suspected outbreak. Respiratory syncytial virus, also known as RSV, is a member of the genus Pneumovirus. It causes croup, bronchitis, bronchiolitis, and interstitial pneumonia. RSV is the most common cause of severe lower respiratory tract disease among infants and young children worldwide. Because infection does not confer complete immunity, multiple infections can occur throughout life, and they can be severe in older adults, the immunocompromised, and those with cardiac and respiratory problems. Healthcare-associated RSV is a problem in many medical facilities. Recommendations to reduce the risk of nosocomial spread include testing hospital personnel and infants with upper respiratory tract infections for RSV, isolating infants with RSV infection, following good hand washing and personal protective equipment practices, limiting visitation, and organizing patient and staff members into cohorts. RSV can be a significant cause of morbidity and death in older patients. RSV spreads mostly through large particle droplets and contact with fomites, rather than through inhalation of small aerosols. The virus may be carried in the nares of asymptomatic adults. RSV infections occur in yearly outbreaks that last 2 to 5 months and usually appear during the winter or early spring in temperate zones. As mentioned before, RSV can be a significant cause of morbidity and death due to the fact that immunity is not conferred by infection. This puts certain populations at risk, such as the older adults, immunocompromised, and those with cardiac and respiratory problems. RSV can be identified in specimens from nasopharyngeal swabs and washes by using DFA or EIA. Because the virus is extremely fragile, recovering it from cultures is difficult. Rapid antigen detection kits are also available for RSV testing, along with several PCR-based molecular tests, with most taking less than an hour to provide the result. Molecular tests are normally coupled with other respiratory viral markers. With the rise of RSV infection in older adults, molecular testing will become much more prevalent, facilitating more rapid treatment and isolation. The antiviral compound ribavirin is approved for treatment of RSV infection. However, some controversy exists regarding the efficacy of therapy using this compound. No gold standard exists for recommendations for treatment, and no vaccine is available for RSV. Human metapneumovirus was first described in children with previously virus-negative cultures. Infected children display many clinical symptoms similar to those of infections caused by RSV, influenza virus, and parainfluenza virus. Often, these diseases are ruled out early in diagnosis, which leads to a presumptive ID of human metapneumovirus. Clinical disease varies from a mild upper respiratory tract infection to acute lower respiratory tract infection. Symptoms can include fever, non-productive cough, sore throat, wheezing, congestion, shortness of breath, and lethargy. Swabs collected from the nostrils are the specimen of choice for human metapneumovirus. Once collected, they're placed in transport media and transported to the laboratory on ice. Cell culture and molecular assays are used to detect human metapneumovirus. Picornaviridae is one of the largest families of viruses with more than 280 members. It contains many important human and animal pathogens and causes various conditions. Picornaviridae are small naked viruses that cause conditions such as fever of unknown origin, aseptic meningitis, paralysis, sepsis-like illness, pharyngitis, pericarditis, pleurodenia, conjunctivitis, skin conditions, and pneumonia. Enteroviruses are members of the family Picornaviridae. The enteroviruses found in the genus Enterovirus include enteroviruses 73 to 120, rhinovirus A to C, polioviruses 1 to 3, Coxsackie viruses A1 to A24, and Coxsackie viruses B1 to B6, and echoviruses 1 to 33. Enteroviruses are more prevalent in areas with poverty, overcrowding, poor hygiene, and poor sanitation. The virus is transmitted via aerosol inhalation, the fecal-oral route, or on fomites. The port of entry for enteroviruses is through the alimentary canal via the mouth. Enteroviruses replicate in the lymphoid tissue of the pharynx and gut, and this may result in viremia and the virus spreading to the spinal cord, heart, or skin. Specimens for enterovirus testing must be collected early in the course of infection whenever possible. Specimens of choice include the pharynx, throat, feces, rectum, cerebrospinal fluid, and conjunctiva. Of note, pharynx specimens should be collected before onset of symptoms and for 1 to 2 weeks afterward. Stool samples can be collected up to 6 weeks afterward. Polioviruses fall within the genus Enterovirus. They infect the nervous system and can cause paralysis. They've also been known to cause temporary intestinal damage. Unlike the intestinal damage, once neurons are damaged, they are not replaced, so this results in death and permanent paralysis. Of all the enteroviruses, poliovirus is the only one of which a vaccine is available. There's several vaccines produced that have antibodies that protect against invasion of the meninges, thus preventing the CNS involvement and poliomyelitis. A disease that you may have heard of, hand, foot, and mouth disease, is caused by the enterovirus Coxsackie virus A. It's caused primarily by types A5, A10, and A16. Coxsackie virus A is a naked, single-stranded RNA virus that's transmitted via the fecal-oral route or on fomites. Symptoms of Coxsackie virus A infection include malaise, headache, abdominal pain, and small painful sores on the tongue, buccal mucosa, and soft palate. A maculopapular rash also appears on the hands, feet, and buttocks, along with blisters that appear on the hands and feet, specifically on the soles of the feet and the palms of the hands. Testing for Coxsackie virus A includes collection of a swab from the mouth or blisters in which the virus can be detected. Rhinoviruses are small, naked, single-stranded RNA viruses that are resistant to detergent and lipid solvents. They're pH sensitive below 6, and more than 100 serotypes exist. Rhinoviruses are transmitted by aerosol droplets and on fomites. Rhinoviruses are the causative agent of the common cold, so they include symptoms of nasal congestion, runny nose, sneezing, headache, sore throat, cough, and sometimes bronchitis, but rarely fever. Rhinovirus infections are generally increased during the winter and spring months. The next family we'll discuss is Retroviridae. Members of this group are known as retroviruses and have a unique mode of replication. They require an RNA-dependent DNA polymerase to synthesize DNA from the RNA genome. These viruses are not cytolytic, but are associated with several leukemias, sarcomas, and lymphomas. Retroviruses are classified into 2 subfamilies, Oncovirinae and Lentivirinae. Oncovirinae contains the human T lymphotropic virus 1, 2, and 5, which are known to cause leukemias, sarcomas, and lymphomas. The subfamily lentivirinae includes human immunodeficiency virus 1, HIV-1, and HIV-2. HIV is a spherical virus with a 3-layer structure. It's enveloped single-stranded RNA, and in the center of the virus are 2 identical copies of the single-stranded RNA and reverse transcriptase, surrounded by an icosahedral capsid. The nucleocapsid is enclosed by a matrix shell to which an envelope of the host cell origin is attached. Viral glycoprotein trimers or spikes are inserted into the viral envelope, and they're diagnostically important in identifying HIV. The HIV structure appears as a spherical enveloped virion with a central cylindrical nucleocapsid. At the virion core lies the 2 identical single-stranded RNA, along with the reverse transcriptase. Surrounding the RNA lies the capsid shell, which has an icosahedral shape. The proteins that constitute the shell are called capsid proteins, and the major one is P24. The rest of the virus has a similar structure to other viruses described. There's proteins under the envelope that are called matrix proteins that serve to hold the glycoprotein spikes that are across the lipid bilayer. The surface glycoproteins are referred to as GP, such as the GP120 or the GP41. HIV is transmitted via blood and exchange of other body fluids. HIV is cell-associated, so fewer viruses are found in cell-free plasma than in whole blood, and even fewer are found in saliva, tears, urine, or breast milk. HIV is not highly contagious, and normal social, non-sexual contact poses no threat to individuals. High risk for contracting the virus includes unprotected sex with multiple partners, IV drug use, infusion of blood and blood products, and presence of virus in pregnant women who passes it to the fetus during pregnancy. In the United States in 2014, the percentages of new cases were associated with the following. 24% were associated with heterosexual contact, 66% were associated with men who have sex with men, 6% of cases were intravenous drug users, 3% were heterosexual contact and IV drug use, and 1% of HIV cases were from transfusion of mother to infant. Once the human immunodeficiency virus enters the body, it primarily targets cells, specifically CD4 T cells, monocytes, and macrophages. Acute infections with the virus are generally mild and can resemble infectious mononucleosis. Patients then can enter a clinical latency in which the virus is rapidly replicating in the background in lymphoid tissue. The virus destroys T helper cells that are critical in the immune response to infectious agents, so then patients begin experiencing several chronic and recurrent infections. With time, opportunistic infections become more severe. Then patients can also develop virus-induced cancers. Death usually occurs from the resulting opportunistic infections. Once human immunodeficiency virus progresses to AIDS, patients can be more susceptible to opportunistic infections and cancers. Box 29.1 from the textbook lists some commonly seen infections in patients with AIDS. So you'll see there's several infections caused by candida and yeasts, along with mycobacteria species. There's also cancers such as Kaposi sarcoma or lymphoma that are more commonly seen in AIDS patients. Clinical manifestations of HIV infection include central nervous system involvement as well as other neurologic problems. Also, opportunistic infections, tumors, and Kaposi sarcoma as mentioned on the previous slide in Table 29.1. Laboratory diagnosis for HIV infection is generally based on the demonstration of anti-HIV antibodies, and in some cases detection of viral antigens and RNA. This can be done using EIA or IF. Rapid screening assays are also available that use serum, plasma, or saliva, and they have similar technology to that of an ELISA assay. Current CDC guidelines published in 2014 recommend using any screening test to detect HIV 1 and 2 antibodies and P24 antigen. No further testing is required if the test is negative, but any reactive tests should be done in duplicate with a screening method and then sent for confirmatory testing if the duplicates are confirmed reactive. Western blot is a confirmatory test that is used for HIV laboratory diagnosis. A positive result is indicated by greater than or equal to 2 bands of P24, GP41, and GP120 or 160. Indeterminate results are indicated by 1 band or other bands not listed above, such as P66, P51, P31, P17, or other bands. A negative result is indicated by the absence of any bands in the Western blot method. EIA assays and other tests can be used but are preliminary due to cross-reactivity. Positive EIAs should be retested in duplicate and require confirmation. This is an example of an HIV immunoblot. So the reactive protein bands appear as purplish lines across the strip. The higher molecular weight proteins appear at the top of the strip. Results are listed as negative, indeterminate, or positive based on the results on the strip. As mentioned before, positive results correspond to 2 or more of the following antigens: P24, GP41, or GP120, GP160. Indeterminate results are indicated if 1 or more bands in the pattern don't satisfy the above positive criteria. And negative results are indicated by the absence of any bands on the strip. Important immunologic markers for AIDS are listed in box 29.2 in the textbook. The markers include a steady decline in the number of CD4 T cells, depression of the CD4 to CD8 cell ratio to less than 0.9, with the reference value being less than or equal to 1.5. Functional impairment of monocytes and macrophages, decreased natural killer cell activity, and anergy to recall antigens in skin testing. Because HIV readily develops resistance to drugs, infection is often treated with combination therapy. The cocktail of drugs is known as HAART, highly active antiretroviral therapy. It's very expensive and hard to implement in poor or developing countries. Despite aggressive therapy, a cure is not generally achieved. HIV viral load assays are required to predict therapeutic efficacy. PCR-based testing is used to assess the viral load. The previous slides discussed genuses in the family Retroviridae. Now we're moving on to the next family, Rhabdoviridae, which includes lysoviruses, the causative agent of rabies. Lysoviruses are endemic in most areas of the United States. It's a very diffuse animal pathogen that can infect humans. Raccoons, skunks, bats, foxes, cats, dogs, cattle, and coyotes have all been implicated in rabies infection, with dogs being implicated in 99% of rabies deaths. Laboratory diagnosis of rabies involves determining whether an animal that has bitten a human has rabies. The animal is then killed and its head is removed and sent to a reference laboratory. The fastest and most sensitive method of identifying rabies virus in the specimen is by using a direct immunofluorescence technique and examining the brain tissue. Rabies is transmitted by bites or scratches from infected animals to humans. Symptoms of lysovirus infection include pain at the exposure site, vague flu-like symptoms, and personality changes. Late stages of infection involve central nervous system changes, such as hallucinations, paralysis, excessive salivation, hydrophobia, bouts of terror, seizures, respiratory and cardiac problems, and ultimately, infection leads to coma and death. Rabies cannot be successfully treated once symptoms appear. However, post-exposure prophylaxis is 100% effective in preventing disease if the bite victim is treated immediately after exposure. Post-exposure prophylaxis includes vigorously cleaning the wound site, providing human rabies immunoglobulin, and administering a 3-injection series of the rabies vaccine. Members in the family Togaviridae include alpha viruses, rubevirus, and arterivirus. Alpha viruses include Eastern equine encephalitis, Western equine encephalitis, and Venezuelan equine encephalitis. Rubevirus includes rubella virus. Arterivirus has not been associated with any human cases of infection. Eastern equine encephalitis has symptoms that range from influenza-like illness to encephalitis. The mortality rate of this infection is about 40% of the cases. Those who survive, almost 50%, suffer permanent central nervous system damage. The natural reservoir for the virus are birds, and then it's spread to humans and horses through the bite of mosquitoes. Western equine encephalitis can sometimes be asymptomatic. With mild infection, symptoms such as fever, headache, nausea, and mental status changes occur. Patients can develop encephalitis. 30% of infected children and infants suffer permanent central nervous system damage, and the mortality rate for infection is 3%. Venezuelan equine encephalitis includes symptoms of influenza-like illness and encephalitis in children. Mortality with Venezuelan equine encephalitis is much less common than individuals infected with Eastern or Western equine encephalitis. Rubella virus is the causative agent of German measles. A mild febrile illness occurs with infection. Symptoms include redness of the skin, a maculopapular rash that starts on the face and moves down the trunk and limbs. There's no rash on the palms of the hands and the soles of the feet. Transient arthritis may occur in children and adults, and there is transplacental transmission to the fetus, which can in turn result in birth defects, fetal death, cataracts in the fetus, and spontaneous abortion. Rubella virus is transmitted via droplets. Nasopharyngeal specimens or any secretion or tissue can be used for laboratory testing. Currently, serologic assays are used to detect rubella virus. Molecular tests are under evaluation, with PCR being used in clinical research trials. An effective attenuated vaccine is available and should be administered to all children and to young women before they become sexually active. The hepatitis viruses are grouped together not because of their structural or genetic similarities, but because they share the same tissue tropism, which is the liver. Over the past 30 years, 8 different hepatitis viruses have been identified. From this list, hepatitis B virus, transfusion-transmitted virus, and SCN virus have DNA genomes, whereas the other hepatitis viruses have RNA genomes. Despite the morphological and biological differences among the hepatitis viruses, many of the clinical symptoms are similar. Table 29.7 summarizes what we'll discuss in the next slides regarding hepatitis A, B, D, and C. It shows the clinical features of the different hepatitis viruses, along with the mode of transmission and any sequelae. Hepatitis A virus is an enteric virus. It's a small icosahedral naked single-stranded RNA virus. Hepatitis A virus is transmitted via the fecal-oral route through close personal contact or contaminated food. It infects people of all ages, with the highest infection rate in children between ages 5 and 14. The incubation period for hepatitis A viruses is approximately 1 month. Symptoms include a transient viremia, in which the virus reaches the liver and replicates in the hepatocytes. The virus passes into the intestines, and then viral shedding begins and can last for months. In children younger than 5 years old, mild to severe prolonged self-limiting hepatitis occurs, and symptoms include fever, chills, fatigue, malaise, aches, pains, and sometimes jaundice. Risk factors for contracting hepatitis A virus include sexual or household contact with an infected person, daycare contacts, foodborne or waterborne outbreaks, IV drug use, and international travel. Hepatitis A virus is detected using serology methods, such as the hepatitis A virus IgM antibody. Real-time PCR is also now being used. There are vaccines available that are safe and effective for hepatitis A virus. This figure shows a serologic evaluation of hepatitis A virus infection. It shows the rise and fall of detectable antibody IgG and IgM. IgM is detectable within the first 3 to 4 weeks, with the highest titer peaking at 6 weeks. IgG is detectable after 4 weeks and increases and then plateaus. Recovery for hepatitis A virus infection can take weeks to months. Hepatitis B virus is an enveloped, partially double-stranded DNA virus that belongs to the family Hepatadiviridae. The virus contains the hepatitis B surface antigen, which circulates in the bloodstream. Hepatitis B virus can cause chronic hepatitis, and it's a blood-borne pathogen. It's transmitted via sexual, perinatal, or parenteral routes. The high-risk groups for infection with hepatitis B virus include IV drug users, men who have sex with men, individuals from endemic areas, household contacts of those with HBV, those with tattoos and piercings, healthcare personnel, and infants born to HBV-positive mothers. Vaccines are available to prevent hepatitis B virus infection. Symptoms of infection include fever, anorexia, hepatic tenderness, sometimes jaundice, and elevated serum aminotransferase levels. Hepatitis V virus infects the liver cells, and they then undergo immune-mediated destruction, causing the symptoms. 90% of hepatitis B infections resolve without serious sequelae, but 10% of individuals become chronic carriers, and these people then become high risk for cirrhosis or hepatic carcinoma. Box 29.3 in the textbook shows the serologic markers for diagnosis of HBV infection. So hepatitis B surface antigen is the envelope protein consisting of 3 polypeptides. Anti-HBs is the antibody to hepatitis B surface antigen. Anti-HBc is the antibody to hepatitis B core antigen. HBeAg is the antigen associated with the nucleocapsid, also found as soluble protein in serum. And anti-HBe is the antibody to hepatitis B e antigen. Table 29.8 shows interpretations of hepatitis B serologic markers. Convalescence or past infection is indicated by anti-HBC and anti-HBs positive markers. Acute infection is indicated if HBsAg and anti-HBc IgM are positive. Figures A and B show serologic evaluation of HBV infection. Figure A is presentation in acute hepatitis infection with resolution. The anti-HBs positive indicator shows either past infection or immunization, but anti-HBC indicates past convalescent infection with positive anti-HBs. Figure B shows chronic hepatitis infection with late seroconversion. Here, anti-HBe positive indicates that chronic infection has occurred. Hepatitis D virus is a delta hepatitis. It's a defective virus that requires hepatitis B virus for replication. It requires the hepatitis B surface antigen as its envelope. HDV is transmitted via blood and blood products or sexual contact. Risk factors include IV drug users and limited numbers of men who have sex with men in certain locations. Hepatitis D infection is rare but usually severe and results in acute disease with a fatality rate of 5%, or chronic symptoms progressing to cirrhosis in 2/3 of those infected. The infection can occur in one of two clinical forms, co-infection or superinfection. In co-infection, the patient is simultaneously infected with HBV and HDV. In superinfection, HDV infection develops in a patient with chronic HBV infection. Patients with superinfection have a more severe acute infection and have a higher risk of fulminant hepatitis compared with patients with co-infection. Long-term carriers of hepatitis B virus who become superinfected with HDV also develop chronic HDV infection, which increases their chances of developing cirrhosis. Diagnosis of HDV infection requires serologic testing for specific HDV antibody. Commercial tests are available for HDV IgG. Reference labs may also offer IgM and HDV agglutination testing and PCR. Table 29.9 provides an interpretation of hepatitis V virus infection serologic markers. For co-infection, you'll see that all the serologic markers are positive, whereas in superinfection, only the hepatitis B surface antigen and the anti-HDV are positive. These figures show a serologic evaluation of hepatitis D virus infection. Figure A shows hepatitis B and D co-infection. Here you'll notice that abnormal liver function test results appear between 2 to 4 weeks. Figure B shows hepatitis B and hepatitis D virus superinfection. Note the prolonged abnormal liver function test results starting at 3 weeks. Hepatitis C virus is a blood-borne pathogen that's transmitted via blood or blood products or sexual contact. Risk factors include blood exposure, usually due to transfusions, sometimes sexual contact, and IV drug use. After methods for diagnosing hepatitis A and hepatitis B virus became available, it became apparent that these two were not responsible for all the hepatitis cases, especially in those related to blood transfusions. HCV was originally termed non-A, non-B hepatitis. Symptoms of hepatitis C virus may be subtle and take time to become apparent. Acute hepatitis occurs but is less severe than that with hepatitis B virus infection. Chronic carriers can occur in 50% of patients infected with hepatitis C. 20% of chronic carriers develop cirrhosis within 20 to 30 years, and cirrhosis then increases the likelihood of liver cancer. Hepatitis C virus has the highest mortality rate among hepatitis A, B, and C. Most laboratory testing for hepatitis C virus is done via serologic testing. Gene amplification tests has also been done and proved that HCV RNA appears in newly infected patients in as little as 2 weeks. Anti-hepatitis C virus antibodies do not produce lifelong antibodies, so persistence of these antibodies indicates chronic infection. Other detection methods in the laboratory include ELISA testing and recombinant immunoblot assays. Hepatitis E virus is a small, naked, single-stranded RNA virus. Hepatitis E virus is transmitted via the fecal-oral route, particularly through contaminated drinking water. It has been identified as a cause of epidemics of enterically transmitted hepatitis in developing countries such as Asia, Africa, and Central America. Although the virus has not been associated with outbreaks in the United States, it has been linked to sporadic cases in travelers returning from endemic areas. Hepatitis E virus causes an acute self-limiting disease with clinical symptoms similar to those of hepatitis A virus. Symptoms of hepatitis E virus include fever, malaise, nausea, vomiting, jaundice, and dark urine. The mortality is between 1 to 3%, with a greater mortality of 15 to 20% in pregnant women. An ELISA test has been developed to detect IgG and IgM antibodies to hepatitis E virus, although Hep E virus testing isn't currently performed in diagnostic laboratories in the United States. Other hepatitis viruses include hepatitis G virus, SEN virus, and TTV, transfusion-transmitted virus. Hepatitis G virus is not common in the United States, and its clinical significance is still under investigation. SEN virus has a circular DNA genome. It's a blood-borne pathogen, and although originally suspected to be a cause of hepatitis, it's not definitively linked to any human disease. Transmission appears to be linked to blood transfusions. Transfusion-transmitted virus is a single-stranded DNA virus related to animal circoviruses. The role of TTV in human disease is unknown, but it may be associated with some cases of post-transfusion hepatitis. Now we've completed the list of viruses, and we'll move on to prions that are covered in this chapter, although they are not truly viruses. As mentioned before, prions are not viruses. They're proteinaceous infectious particles that cause a group of diseases known as transmissible spongiform encephalopathies. TSCs are characterized by progressive, relentless degeneration of the central nervous system, which is ultimately fatal. Typical histopathology is neuronal evacuation and eventual loss of neurons, accompanied by proliferation and hypertrophy of the fibrous astrocytes. The prion protein, PRP, found in animals with TSC is often referred to as PRPSC, named after the prion found in the sheep with scrapie. Animals, including humans, have a similar but normal protein found on the cells of the central nervous system referred to as PRPC. Ingested PRPSC is absorbed into the bloodstream and makes its way into the central nervous system. PRPSC converts the normal PRPC into the mutant strain, which is released by neuronal cells. PRPSC accumulates in the central nervous system, producing amyloid plaques and the characteristic histopathology. Recent studies have also suggested the excretion of the TSCs in urine, aside from the histopathological specimens. The name prion came from the words protein and infection. Prions are transmitted through ingestion, and then that in turn affects neural tissue, resulting in progressive central nervous system degeneration. There may be cases of other tissue transmission, but typically it's ingestion affecting neural tissues. Examples of prions in animals include scrapie in sheep, chronic wasting disease in mule, deer, and elk, transmissible mink encephalopathy in mink, and then one that we're probably all familiar with, mad cow disease in cattle. Clinical manifestations of transmissible spongiform encephalopathies include progressive, relentless degeneration of the central nervous system that is ultimately fatal. Symptoms include dementia, memory loss, behavioral problems, cerebellar ataxia, and shivering like tremor. Complete loss of motor and speech function can occur, and death progresses in 1 month to a year of infection. Bovine spongiform encephalopathy is the infection that affects cattle. Humans develop an illness from infected meat of the cows with bovine spongiform encephalopathy. The human infection is known as Creutzfeldt-Jakob disease. Another form of transmissible spongiform encephalopathy is Kuru, which occurs in New Guinea in the Aborigines population. Diagnosis of transmissible spongiform encephalopathies is often based on clinical findings. Available methods for testing include histopathology stains and PRPSC protein immunostaining that are considered the most specific diagnostic methods. Other methods include antigen detection, serologic testing, and nucleic acid sequencing for inheritable forms. Caution should be used when handling suspected materials because prions are able to survive formalin fixation and they're very resistant to sterilization. It's recommended that 20,000 parts per million of chlorine or 1 molar sodium hydroxide be used to inactivate the prions. It's not recommended to test any specimens from suspected cases of prion disease until it is ruled out because instrumentation cannot be sufficiently decontaminated and it presents risk of infection to hospital staff and other patients as well. Now we've discussed the various viruses and touched on prions. The last thing to discuss is antiviral therapy. So we've seen through several slides that some viral infections are treatable, especially if laboratories can rapidly identify the pathogen. The antiviral compounds must target the essential viral replicative mechanisms without destroying or damaging uninfected host cells. Use of antiviral compounds increase the risk of drug resistance, so antiviral susceptibility testing will become increasingly important in the coming years. Examples of antiviral compounds and the target mechanisms that they disrupt are listed in Table 2910. Examples include the antivirals for viruses such as HSV, varicella, and CMV, so those compounds inhibit DNA polymerase. Acyclovir for HSV or cidofovir for CMV are examples of those DNA polymerase inhibiting compounds. Another method of inhibition is reverse transcriptase inhibition. So you can see several of the compounds for HIV target the reverse transcriptase. As mentioned before, just as antibacterial agents, the usage increases the risk of drug resistance, the use of antiviral agents can result in viruses that become resistant to therapy. So as more antiviral agents are developed, it becomes increasingly important to determine susceptibility of these compounds. So this concludes part 2 of chapter 29. So we've seen there's numerous viruses and they're associated with a wealth of illnesses. And viral illness still continues to be a significant problem for large segments of people throughout the world. Although we have controlled many viruses over the years, new ones emerge, as we've seen with Zika and prions. So this field is continually changing and challenging.